Good evening, everyone. Thanks very much for coming out tonight for dinner and some brain food as we kind of go through some of the new data we've heard here at ASCO and try to put it into practice and try to get as practical as we can about all the options we have for patients and the coming options, because there's really a very dynamic landscape. And the title of our program tonight is Rising to the Challenges of Early and Advanced HR-Positive Breast Cancer, Examining Complex Evidence to Inform Clinical Decisions. Thanks to PeerView for getting us all together tonight. I'm Joyce O'Shaughnessy, breast medical oncologist at Baylor in Dallas, Texas Oncology and Sarah Cannon Research Institute. And I'm really pleased to be joined by two longtime friends and expert breast cancer physicians, educators, and researchers. Javier Cortes, who's head of the International Breast Cancer Center in Barcelona, Spain, and Cynthia Ma, professor in the Division of Oncology, Department of Medicine, Washington University. Thanks so much for being here. Really a pleasure to do this with you tonight. So thank you again all very much for coming. Hopefully this will be very useful for you in your practice. So again, thank you to PeerView, GRASP, and Living Beyond Breast Cancer for providing this educational session. Very much appreciated. AstraZeneca, Genentech, and Lilly for providing the educational grants for this session. And please take part in the audience polling throughout the program, because there's before and after, there'll be the same question asked. So it's a measurement of learning or just changing your opinion about things. So that kind of measurement is very, very important to CME, as you well know. So, and please submit your questions and we'll answer them during the Q&A session. So we've allotted some time for questions, so please go ahead and submit them. And instructions for submitting questions and polling are on the next slide. So for the in-person learners, you can scan this QR code with your personal device. Let me go back there. With your personal device to answer the polling questions and ask the faculty your questions. So you just need to scan the QR code. You'll be able to ask the questions as well as do the poll. So the QR code instructions are on your mobile device. Open the camera app, tap on the QR code, just hold it up to the QR code, tap on the QR code to focus the camera, and then click the link. There'll be a link that appears. Just click that link. It's really, really amazing how that happens. Now, PeerView, as you know, has a lot of enduring materials, a lot of educational materials. So you can view the slides from tonight's program and practice aids, the practical application of the data we'll discuss tonight at the PeerView site shown there, 2024 HR Breast Cancer. So feel free to, you can download the slides, download the practice aids, so they're really there for you. So our goals for today are to augment your knowledge and understanding of the key data on current and emerging treatment options for patients with HR-positive, HER2-negative early breast cancer and metastatic breast cancer, equip you with the skills to conduct risk assessment and biomarker testing, and individualize the treatment selection and sequencing in HR-positive, HER2-negative early and metastatic breast cancer, and then enhance best practices for team-based collaboration to optimize treatment adherence, persistence, and manage AEs associated with the latest therapies for HR-positive, HER2-negative early and metastatic breast cancer. So we'll be focusing both on early stage and metastatic disease. So we've partnered with GRASP and Living Beyond Breast Cancer in this program. And so please review and download the supplemental resource compendium, which includes information and educational materials for your patients to help them become better informed and engaged participants in their care, helps that shared decision making. So they have some very, very nice resources. So we're going to start with part one tonight, which is Candid Conversations and Clinical Consults, HR-positive, HER2-negative early breast cancer, stratifying risk and reducing the risk of recurrence with adjuvant CDK4/6 inhibition. It's a pleasure to turn us over now to Javier Cortes. Oh, actually, you know what? I'm sorry. Actually, let me read this. I'm sorry. Yeah, not quite. Okay, good. So let's start with the case. A 59-year-old postmenopausal woman who is a violinist in an orchestra presents with a mass in the right breast discovered on routine mammogram. Further assessment is undertaken, followed by surgery with the following results. Mammogram ultrasound shows a 2.8 centimeter mass and an enlarged suspicious axillary lymph node. Core biopsy shows grade 3 invasive ductal breast cancer, ER 90%, PR 25%, HER2 negative. Lymph node biopsy is positive for carcinoma, and PET CT scan staging and germline testing are negative. So she undergoes a mastectomy and axillary lymph node dissection, and she has a 2.6 centimeter grade 3 invasive lobular breast cancer. 2 of 3 nodes are positive. So a T2N1 grade 3 invasive lobular breast cancer. So please, you can just scan the QR code to bring up these options for the polling question here. So based on the information you have about this 59-year-old woman, which endocrine therapy-based adjuvant treatment would you recommend to this patient? So 1, endocrine therapy with an aromatase inhibitor for 5 years. 2, endocrine therapy with an aromatase inhibitor for 10 years. 3, endocrine therapy with aromatase inhibitor for 2 years, with 2 years of adjuvant abemaciclib. 4, endocrine therapy with an aromatase inhibitor plus 3 years of adjuvant abemaciclib. 5, I need more information to determine her risk status and the best treatment approach. Or 6, I'm not sure right now. So if you would kindly go ahead and vote. Okay, so we're going to come back to that question again after we hear from Javier and after we have some discussion. We're going to come back to that question again and see what your adjuvant strategy would be. So now I can turn it over to Javier. Here we go. You got it. Great.
Thank you very much, Joyce. Thank you very much also PeerView for inviting me to be here with these 2 friends, 2 colleagues, and to discuss about the role of endocrine treatment and CDK4/6 inhibitors in the early breast cancer setting first, and of course we'll discuss about metastatic breast cancer afterwards. And I think what we always say, I think the best way or the most important objective of this type of events is always to have a lot of discussion. So everything is very well known by all of you, many times even more or better than what we know, but what is really interesting is to have a great discussion. So we would love you to have a lot of questions and to agree and disagree, because, you know, clinical practice is much more difficult than clinical trials. So I think that's the beauty here. And this patient, for example, will have different options maybe or not. But again, in the clinical practice, we will have a lot of discussion, and that's something that happens every time. So let me start with how to consider or what to consider in risk assessment. And you know that this is not triple-negative breast cancer. I think that sometimes when you have a patient in your clinic with node-positive disease, you say, wow, if this is not HER2 positive, please, I wouldn't like this to be triple-negative. But let's take some considerations, and let me ask you something. What would you prefer? To have a patient with stage 2 or stage 3 triple-negative breast cancer if the disease-free interval is longer than 5 years, or do you prefer to be ER positive? So why am I saying this? Because as you can see on this slide, in triple-negative breast cancer is not here. After 5 years, it's very difficult the patient to experience progressive disease. However, in hormone receptor-positive tumors, even after 10, 15 years, you might have metastasis. So that's something that sometimes we forget. And look at the figure on our right. You can see here that even with stage 2 disease, after 10, 15, 20 years, there is a significant number of patients who continue to experience progressive disease. So I think that this is something that, unfortunately, we have to take into account when we have to assess the risk of a patient to experience disease progression locally or distant metastasis. So one of the most important aspects to consider the risk of recurrence is to define the endocrine resistance. And there are different ways to look at that. For example, we all know that the more the tumor proliferative is, the more risk the patient may have. Also, the lower the estrogen receptor is, the higher the risk will be. But we can also look at this looking at a different genomic profiling. For example, this. And we all know, patients with node-negative disease, when we have a low risk, intermediate risk, or high risk, look at the high-risk patient population with tamoxifen, there are 30% of patients that might experience progressive disease. So again, we are looking at estrogen receptor positive tumors as a disease which is curable, and it is, but we should not forget that after 5-10 years, unfortunately, many patients still will experience progressive disease. You know this data. This comes from Peter Smith, and it is based also on his perception. But I would agree with that. So we, in general, we have different platforms in the clinical practice. We have prospective phase 3 studies from Oncotype or from MammaPrint. And here we have a table summarizing what we do sometimes in the clinic. In postmenopausal women, if we have node-negative disease, if the recurrence score is lower than 26, so 25 or lower, we usually might consider endocrine treatment. If it is higher than, we should consider chemotherapy. Of course, it's not always black or white, but it's like a general approach. In the premenopausal women, the cutoff values are completely different. Between 6, we could discuss if we go for chemotherapy. 21 or higher, there are enough data to suggest that chemotherapy might have some benefit. Of course, 15 or lower, endocrine treatment. For the node positive 1 to 3 lymph nodes is totally different. The cutoffs are different here, same for postmenopausal, but according to the premenopausal status in the Responder X trial, all patients benefited from chemotherapy. And you can see here, from 0 to 10, we selected maybe endocrine treatment, but that's something that is not so clear. And that is why there is an ongoing clinical trial, which is BR 009, which is very impressive. I think this trial is basically evaluating if in premenopausal women with a low recurrent score, we can omit chemotherapy if we provide ovarian function suppression. I think that's a very good approach. It seems that the role of chemotherapy, at least in some of these patients, is not because of the chemotherapeutic aspect, it's because chemotherapy might produce an ovarian function suppression. So this trial will answer that question. Now, let me just summarize the key aspects from the ADAPT trial. ADAPT trial is a very interesting study, conducted basically by the group of Nadia Harbeck. And what they did was to consider recurrence score and Ki-67. Ki-67 is still widely used, at least in Europe. I don't know if in the United States continues to be very widely used, but in Europe it is. And what they did was given endocrine treatment for 3 weeks. They took a biopsy, or they went for surgery, and they look at Ki-67 again. If the patient did have N2, N3, or recurrence score more than 25 after these 3 weeks of treatment, patients received chemotherapy. But if N0 or N1, and look at the number of patients, almost 3,000, the recurrence score was between 12 to 25, but high Ki-67, chemo. Recurrence score, 12 to 20. Doesn't like what I'm saying. So, 12 to 25. By Ki-67 low, experimental arm. If recurrence score lower than 12, endocrine treatment. So basically, this is totally different. These are pre- and postmenopausal women, but this included also premenopausal. This is totally against what we learned from the responder. So in this trial, we analyzed the role of looking at the biology after 3 weeks of tamoxifen or aromatase inhibitors to de-escalate treatment. But look at here the results. So, of course, if the Ki-67 was lower or higher than 10, the number of patients who received chemotherapy was completely different. But regardless the age of the patient And regardless if they received more or less chemotherapy, those tumors with a reduced Ki67 at the time of surgery did have much better outcomes compared with those patients who continue to have a Ki67 higher than 10%. So a very strong, very potent prognostic factor. Now, let's now try to integrate the CDK4 and 6 inhibition in this patient population. Can we optimize the role of endocrine treatment for patients with high risk? And we have here 2 clinical trials that, again, you know very well. I'm going to review very quickly the key aspects to be able afterwards to discuss the clinical case and maybe to have a great discussion. So this is Monarch E. In Monarch E, we have 2 groups of patients. The first one, patients with 4 nodes or more, or patients between 1 and 3 nodes if at least grade 3 or tumor size higher than 5 centimeters, T3. And there was a cohort 2, group 2, with 1 to 3 nodes, but the Ki67 was higher than 20%, and tumor size should be lower, grade should be 2 or 1. So patients were randomized to receive 2 years of abemaciclib plus endocrine treatment or endocrine treatment alone. 2 years, not 3 years. 2 years. Why? It was totally arbitrary. We do not have any rationale to support 2 years and not 2 years and a half, 1 year and a half. I don't know if you have more data. No. I think it was totally arbitrary. But nevertheless, this is what they did. So, primary objective, invasive disease-free survival. 2 comments about the primary endpoint. The first one, we observed very early on time an improvement in invasive disease-free survival. But the second key aspect is that we have observed a carry-over effect. So it seems that the more follow-up we have, the more benefit, the more absolute benefit we observed. And that's very interesting. This is something that we also observed with tamoxifen from the very beginning. So once we stop treatment, we continue to observe something better and better and better over time. Look at here, the 3-year, the 4-year, and the 5-year absolute benefit in invasive disease-free survival in the range of 7.8%. Second comment, can we identify a group of patients who will not benefit from adjuvant abemaciclib? From the clinical perspective, we cannot. You can see here that the confidence intervals are all of them overlapping. Third aspect, and this is really important. Is it very important, very interesting to decrease a little bit local or secondary breast cancers? I'm not sure. Now it's perfect. I'm not sure. I wouldn't give abemaciclib, to be very honest, to decrease new breast cancers by 2 or 3%. I wouldn't do it. But look at this data. What we did is to reduce the number of metastases. What we are doing here is to decrease distant or to increase distant relapse-free survival. And this was by 7%. Remember in Keynote 522, it was by 7 to 8%. So the degree of efficacy in reducing metastases was similar to Keynote 522. And in my opinion, this is what really matters. And that's why, in my opinion, again, can be biased here, it's my opinion. That's why I think that abemaciclib is considered, should be considered, at least for me, one of the best options to treat these patients. Now, overall survival. Of course, we do not have overall survival. Of course. It means that once we have metastases, God thanks, patients live longer and longer and longer. I would love not to have survival benefit. It would mean that patients will live forever with metastases. Unfortunately, in 5 years, we will see survival advantage. And this is not good news at all. This means that patients die with metastases. Well, nevertheless, the payers look at 2 systems. I will leave it there. So, you can see here this in another way. So, at overall survival interim analysis 3, you can see that there are many more patients living with metastases. In the control arm, compared with in the abemaciclib arm, which is very good news to prevent metastasis, which at the end is the most important objective, in my opinion. So last year at San Antonio, Nick Turner presented the data of different biomarkers. And I would like to highlight two analyses here. The first one, he analyzed the benefit of adding abemaciclib depending on oncotype. And what did we observe? That doesn't matter if it was more than 25 recurrence score or lower than 25. The benefit was exactly the same. And afterwards, we did something which I think is quite interesting, looking at the same strategy based on the PAN50 subtypes. And here you have the results. Luminal A, luminal B, HER2-enriched, and basal. Exactly the same benefit from all the subtypes. Which are the two conclusions here? We don't need to do profiling analysis. Easy. I don't like to do it, to be very honest, but good. And second, all patients benefit the same. Now, don't forget that tomorrow, if you have the opportunity to look at this presentation evaluating the prognostic utility of ctDNA, it will be presented by Serene Loy. Now, treatment discontinuations. You know this data, just to remember. The most important reason for patients to discontinue treatment was diarrhea. And that's an important adverse event because this decreases the quality of life of the patient. So that's something that we should manage properly, except for diarrhea, and in 5% of patients, and 2% because of fatigue. All the others were 0 point something, depending on the adverse events. But in general, without taking into account diarrhea, I think that the toxicity profile was quite reasonable. Now, dose holds and dose reductions, exactly the same concept. The great majority of dose hold or dose reductions were, once again, diarrhea, fatigue, and of course, in some patients, neutropenia. Remember, neutropenia grade 3 or 4 in the range of 19-20%, more or less, with abemaciclib. This is a very important analysis that you presented, Joyce, showing that if we have to reduce the dose because of toxicity, we will not have any impact in the long-term outcomes. So that's very important because sometimes patients come to the clinic and say, no, please don't reduce the dose. No, we can reduce the dose if this is because of toxicity, and this will not have any impact in outcomes. So very, very important analysis for the clinical practice. So you know the FDA and the EMA regulatory approvals. I don't understand why the FDA, at the very first time, did consider only the Ki-67, and if the Ki-67 was low, it was not approved. But afterwards, they realized that Ki-67 is a prognostic marker, but it is not a predictive marker. So patients with whose tumors were higher or lower Ki-67 benefited the same. Now, let's move into NATALEE. NATALEE is the second positive study. We have 4. We have also PALLAS and PENELOPE. Remember, with palbociclib. Unfortunately, these 2 trials were negative, so we are not going to review them because no. So 3 aspects here. The first one, we included some patients with node-negative disease, intermediate to high risk. You can see here, stage 2A, if grade 2 with some other high-risk features, genomic profiling, KI high, etc. Or stage 2B, N0 or N1, and stage 3, N0, 1, 2, or 3. Second aspect, ribociclib. The dose was 400. It was not the classical 600. There is a paper published by Fatima Cardoso in the metastatic setting showing that 400 is quite similar to 600 in terms of activity. Nevertheless, 400 milligrams per day. And last but not least, 3 years of treatment. So NATALEE, 3 years. Abemaciclib, Monarch E, 2 years. Now, results, primary endpoint, invasive disease-free survival. You can see here Also a benefit in terms of IDFS. Absolute benefit at 3 years. The follow-up is much shorter compared with abemaciclib. Absolute benefit, 3 years, in the range of 3%. In Monarch E, at 3 years, it was in the range of 4%. At 5 years, it was, remember, almost 8%. So positive study for invasive disease-free survival. More data. Can we prevent metastasis? We can, in the range of 2.7% absolute benefit at 3 years in decreasing the risk of metastasis. So as expected, of course, we will not have data in terms of survival. We'll see afterwards. So Gabriel Ortobaggi at ASCO presented some subgroup analysis. These subgroup analyses regarding the N0 were updated at ASCO this year with the same basically results. Natalie, ribociclib benefited the same for patients with node-negative disease and for patients with node-positive disease. It benefited the same for stage 2 and for stage 3. Of course, the risk is higher, but the benefit is the same. As I said before, no overall survival advantage. Why not? Because patients with metastasis survive many years, which is, again, very good news. Now, safety. Different compared with abemaciclib, the most important adverse events with ribo, remember, febrile neutropenia, grade 3 and 4 neutropenia in the range of 40 to 45%. Important also a transaminitis, grade 3 in the range of 8 to 9%. ILD pneumonitis was anecdotic. For me, I think that ECG QT prolongation is not very frequent in terms of grade 3, 1% more or less. And remember also the thromboembolism that might happen not only with abemaciclib, but also with the other CDK4 and 6 inhibitors. Now, similar to Monarch E, if we have to reduce the dose because of toxicity, this does not have an impact in long-term outcomes. So don't be afraid if we have to reduce the dose. So basically, these are the data presented this year at ASCO. As I said before, in the node-negative population, we have also a benefit from adding ribociclib to endocrine treatment. Nothing spectacular, nothing new, but nevertheless, we have here the data in case you want to see it. So, going back to our clinical case, I pass the microphone to Joyce. The reason is very simple. She speaks a very much better English than me, so it's much easier for you to understand. Thank you very much.
Awesome. Thank you so much. What a great teacher Javi is. So entertaining and energetic. Love it, love it, love it. So this gal, we're going to come back and vote on her management here in a second. I just want to hear from my colleagues. You know, she's got a T2, N1 invasive lobular. It's called grade 3, so I'm thinking it's a pleomorphic lobular. You know, how would you approach the question of chemo, no chemo? And what would you do for endocrine therapy for? I'll start with you, Javi.
Well, I think that, no, that's a very good question. So, again, as I said before, clinical practice is much more complex because what you have there is not a number, it's a patient. So we have to discuss with them always. But when in my clinical case, in my clinical practice at least, when I have a patient with 1 to 3 nodes and she is post-menopausal, I give the opportunity to check oncotype. So even if this patient seems to be pleomorphic, grade 3, KI high, it's very unlikely to have a recurrence score low, but nothing to lose. It's just to wait maybe 2 to 3 weeks to start chemotherapy. So I usually go for an oncotype. If it is low grade, I go for endocrine treatment plus abemaciclib in this case. If this is high grade, I go for chemo, followed by.
And just tell us how you decide whether to use an anthracycline or not, Javi. Sorry.
So
that's why we're here tonight.
No. We are just starting. Can you imagine afterwards? So, no, I want to be honest. I have used a lot of anthracyclines in the past, but now in the hormone receptor positive field, I have started to decrease the use of anthracyclines. I like the TC 6 times with no positive, but I want to be honest. So I wouldn't use anthracyclines. I want to be honest. I have changed a little bit my schema. I have transformed the TC into the paclitaxel cyclophosphamide. So each T are 3 paclitaxels. So what I do is to go for TC4 or TC6, which means 12 paclitaxel or 18 paclitaxel plus cyclophosphamide. That's what I do.
Weekly paclitaxel.
Weekly paclitaxel, yeah.
Cool. Well, thank you. How about you, Cynthia? How would you approach this gal?
So in regards to chemotherapy question, I agree with Javier that I would also do an oncotype since she has N1 disease and she's postmenopausal. And if it is over 25, I would offer chemotherapy. And the same with anthracycline use. I don't use it often unless there's more than 4 positive lymph nodes, for example.
Mm-hmm. And what about the adjuvant endocrine therapy?
Yes. So, I would definitely choose aromatase inhibitors, based on the data that aromatase inhibitors would be better than, tamoxifen. So, but I would check like bone densities and, issues like that. Make sure that, we protect their bones, with bisphosphonate if needed. And, of course, CDK4/6 inhibitor, I think she would be eligible for that.
Can I ask
Yeah.
you something,
Yeah.
Joyce? And I'd like to hear also your point. So it is true that we have data for N0 or 1 to 3 nodes. But let me assume that you have a postmenopausal woman, let's say 70-year-old or 65, something like that. It has 4 or 5 nodes, but the KI is 1-2%, grade 1. You go for an oncotype because you are mad and you have a recurrence score of 2 or 3. Do you think that we have to go for chemotherapy, or what would you do?
Yeah, I think I may still offer chemotherapy just because I think there could be heterogeneity because of the multiple positive lymph node in the higher stage. I agree, probably not anthracyclines. I might consider TC.
This is an example because I do try to bring in the ADAPT approach.
Okay.
Now, the ADAPT is level 1 evidence, because that was, as you said, a large 3,000 plus patient. It was 5 years of follow-up. And if that Ki-67 suppressed, of course, it had to start above 10 to be eligible. But let's say this patient started above 10. Now, 4 more nodes in ADAPT, they just got chemotherapy, right? So, but when I'm on the borderline, I think it's another piece of information. If you give 3 weeks of preoperative endocrine therapy, they go to surgery and they've suppressed less than 10%. Where I use that is if I have a patient who's premenopausal and she's got very favorable biology, but she's got like 1 small node.
Yeah.
If I can get her before she goes to surgery and give her that, we can get additional information, from her, because not everybody who's a premenopausal woman who's ER positive with 1 node needs chemotherapy, even though we saw that in our exponder. But as you said, it's because they didn't get optimal endocrine therapy. I don't always treat those patients with chemotherapy because it's really highly unlikely that it's going to be beneficial to them with a very, very low recurrence score. I mean, it's the biology is the biology and the anatomy fluctuates, but it would take a lot of conversation. If she was like 55, I probably would treat her, because it's conscious of comorbidities and such,
That makes sense.
Well, thank you guys. We could go on about this topic all night long. There's lots and lots. So this is if you could please use the QR code to pull up that question again about the 59-year-old woman and what you would recommend to her for her adjuvant endocrine therapy, that would be great. So if you could go ahead and vote on that, that will just take a second. Okay, so now our case continues. This woman, she is in fact treated with abemaciclib. And after the first couple of cycles, she has diarrhea, and it's persistent, and it's recurrent, and it's a recurrent grade 2 diarrhea. So what are we going to do for this patient now? How are you managing this, Cynthia? How are you trying to stack the deck so they'll stay on therapy?
Yes, I assume that this patient started at full dose, which is what I normally practice like that. But I make sure that they have like prophylactic, or make sure that they have Imodium available, so that give them the instructions how to use Imodium. So for example, take 2 tablets like after the first one, and then you can take one every 2 hours as needed for maximum of 8 tablets every 24 hours. And then I also would say we can add Lamotrigine if needed as well, so to maximize their antidiarrheal management.
And you see them in the beginning, like every 2 weeks or so?
Yes, because they will need to have lab tests done as well, and you monitor for blood counts as well as liver function tests, and these.
That data that we don't lose efficacy when we get down to 100 was some of the best news I've had in helping patients stay on this medication. I'm much more comfortable going down, and 43% of patients, or 42, needed a dose reduction, and so it's fabulous that we can go down. If it's a recurrent grade 2, that's a lot of diarrhea, you know what I mean? So because I'm really looking to have her stay on, you know what I mean? So that was really, really great news. So now we're going to turn to metastatic breast cancer, HR positive, HER2 negative metastatic breast cancer, talk about some of our new therapeutic options, the latest data that we have from CDK4/6 inhibitors, and just put it in the context of a case as well. So let's start with this case. A 64-year-old postmenopausal woman, a gastroenterologist, has a history of invasive carcinoma of the breast ductal, P, T2N0, grade 3, ER 90%, PR 50%, HER2 negative. Mammogram ultrasound showed a 2.8 centimeter mass and an enlarged suspicious lymph node. She had lumpectomy, adjuvant chemotherapy with TC, and radiation therapy, and adjuvant AI. And 2 years after starting her AI, she develops right hip pain, and imaging reveals lytic bone lesions. And staging scans show extensive liver metastasis, bone metastasis involving the hip, spine, and ribs, and biopsy shows still ER/PR positive, HER2 negative, and germline BRCA1 or 2. I dare say we've all seen patients like this who you expect to do well, and they don't. There's some lethal subclone in there that just doesn't respond to everything you give them. So what first-line therapy would you recommend for this patient? She's recurring after just 2 years on AI. Abemaciclib endocrine therapy, ribociclib endocrine therapy, palbociclib endocrine therapy, or I'm not sure. If you could, again, just use the QR code and go ahead and vote, that'd be great. Okay, so let's go ahead here and talk about the latest evidence on CDK4/6 inhibitors and oral SERDs, and we'll hear from Cynthia about the various ways we can inhibit the PI3 kinase pathway. So let's look at the latest data on CDK4/6 inhibitors, in the metastatic setting. Let's see if we can get this one to stick. Oops. If you could just go ahead with the slide, that would be great. Great, thank you. Oops. Now, if you go back one, please, that might be easier. Just skipping. Okay, great. So these point estimates show the hazard ratios for the reduction in the risk of death in the first-line metastatic first and second-line metastatic CDK4/6 inhibitor trial. So endocrine therapy alone versus endocrine therapy with the various, you can see on the far left, ribociclib at the bottom, abemaciclib in the pink, and palbociclib in the purple. And you can see the dotted line is the 1, where if it's on 1, it's Unity. Unfortunately, Paloma 2 was just about on Unity. Palbociclib, endocrine letrozole plus minus palbociclib, was unfortunately no improvement in survival. These are survival data here, whereas the Paloma 3, it just missed statistical significance, but there was actually a 10-month improvement in overall survival in patients with endocrine therapy sensitive disease per the ESMO definition. And there was not in those that were primary endocrine therapy resistant, which is just a small proportion of our patients, about 15%, but in 85% that were endocrine therapy sensitive, there was an overall survival advantage. So I thought that was very interesting. So did the New England Journal of Medicine, that published it. Now, in Monarch 2, which was the second line fulvestrant plus minus abemaciclib, there was a survival advantage. You can see the numbers down sort of the middle there, the absolute median overall survival with placebo and the CDK4/6 inhibitor. So that was a significant improvement. Monarch 3, I'm going to show you the data here. You can see the point estimate there is a 0.80 in terms of survival. You can see there's a 13.1% absolute improvement in overall survival, but you see the confidence intervals are crossing 1. So I'm going to show you that here in a bit. All 3 of the MONALEESA studies with the letrozole first line with the postmenopausal women, MONALEESA 2, MONALEESA 7 with the premenopausal women, and then MONALEESA 3 with fulvestrant first and second line. You see those hazard ratios 0.76, 0.71, 0.72, 3 positive studies for overall survival with ribociclib in the first line setting. Very, very robust data. This is a long-term follow-up now on the Monarch MONALEESA 2, and we see again this is a 12.5-month improvement in median overall survival. Those curves look like they're still pulling apart. Really, really very, very good data and highly statistically significant. Paloma 2, as I mentioned, unfortunately was negative for overall survival. That's the letrozole plus minus palbociclib. You see it's negative for survival. However, if you go to real-world data, this is a Flatiron database, the P-Reality X trial, and look in real-world evidence for patients who got letrozole or anastrozole first line versus the same endocrine therapy plus palbociclib, and then you pull out their overall survival, and then you do statistical modeling to try to adjust for imbalances in the 2 groups of patients, and that's unadjusted on the left, and the 2 statistical models that are very well accepted to adjust prognostic variables in real-world evidence. You show these are statistically significant improvement in overall survival. So palbociclib in the real-world evidence seems to be improving overall survival, although it did not in the Paloma 2. So we recently had the final overall survival data on Monarch 3, and I'll just review this with you here. It was at San Antonio last year. Again, first-line metastatic therapy, and patients had letrozole or anastrozole with placebo, or the same endocrine therapy with abemaciclib, full dose, 150 twice a day, continued until progression. And these are the final overall survival data, the intent to treat population. As I mentioned, it is a 13.1 month improvement in median overall survival. You can see the hazard ratio over there, 0.8, but the p-value is 0.066. It misses statistical significance. And why would a difference this big not have statistical significance where it did in MONALEESA 3? And the reason is that this was a smaller study, 493 patients versus the MONALEESA. All the other first-line trials were all about 666 patients, so it's about 1/3 smaller size trial. And you need the events. You need the events to really have statistical significance. So that's my interpretation of these data. That had it been a larger study, it would have been statistically significant. So I look more on these data. I look more at the absolute improvement in overall survival than I do the actual p-value. In patients with visceral disease, so that's, of course, lung and liver disease, there is an even larger improvement in overall survival, about 15 months improvement in 14.9-month improvement in overall survival in our sicker patients. And you can see the hazard ratio 0.75, p-value 0.07. And then we had updated PFS data. And so we see that the median PFS, that says OS in the table, but its median PFS is 29 months, with abemaciclib versus 14.8 months. So about a doubling in median PFS. So this is very, very good. We love that tail on the curve. We're at that 72-month mark. At the 6-year mark, 23% of patients still haven't progressed versus 4% on endocrine therapy alone. So this has really been a real nice thing to be able to enjoy these years with our patients who enjoyed these years so very much. There wasn't a subset that didn't benefit, as Javi said. These are, you can see these point estimates. They're kind of on top of each other, and the confidence intervals are totally overlapping. So there wasn't a subset that did not benefit. So let me ask my colleagues what they would do with this woman. She's got about as aggressive disease that we're going to see on HR-positive breast cancer. This is a primary endocrine therapy resistant patient, right? This by the ESMO guidelines. It's within 2 years or within 2 years you recur, and she's got bone, lytic bone, she's got liver, and it's still ER/PR positive. What do you think, Javi?
So 3 quick comments. The first one is we have the right choice, showing that in this patient population, we do not need to start with chemotherapy. So that's my first comment. So I would definitely go for endocrine treatment. Okay. The second comment is that I think that all options are reasonable and all of them are good. So palbo, ribo, or abema. I think that all of them are good options. But I have to choose one. I cannot give all of them. Can you imagine that? So I want to be honest. I think that there are patients for all of these drugs, which are extraordinary, are excellent. But when I have a patient with a significant amount of disease or a short disease-free interval, treatment-free interval, I usually use abemaciclib a little bit more. But again, so that's my comment. I cannot say that this is a patient for abemaciclib. No, that's what I would choose. But I would like to highlight that all 3 options are good here.
Yeah, thank you, thank you. How about you, Cynthia? How do you approach these women?
Yes, I think this case, she has recurrence within 2 years, primary endocrine resistant, and with visceral metastasis, liver lesions. I think with the Monarch 3, you had, more prominent benefit of abema, in these settings. Also, there's Monarch 2, actually, in the fulvestrant in combination. I think the overall survival benefit with abema was also more prominent in the visceral mets and primary endocrine resistance. So I would favor abemaciclib in that setting. I agree, though. I think ribociclib would be fine as well.
Yeah, I really totally agree. I do tend to pick the abemaciclib as well. This is a very genomically unstable cancer. It's a luminal B. And I like the broader mechanism of action. You pick up some more toxicity with regard to diarrhea, but it's got a broader mechanism. It's CDK4/6, some CDK2, CDK9. It's a little broader mechanism of action, but it's mainly the data. It's mainly the data. I think it's got the strongest data in that endocrine therapy resistant population in the liver metastasis patients, which this patient has. So that's what I would do as well. So let's have you folks, if you wouldn't mind, just pull the poll up again and let us know what how would you treat this patient? Just take a minute here. Okay, so we have another case. A 67-year-old postmenopausal woman diagnosed with HR-positive, HER2-negative metastatic breast cancer receives first-line palbociclib and endocrine therapy, but after 18 months, develops asymptomatic progression in bone and 1.5 centimeter new liver lesions. ctDNA testing reveals no ESR1 mutation. Germline BRCA is negative, and she does not have a mutation in PIK3CA, AKT, or PTEN alteration. So she does not have a molecular target to go to. She had 18 months on the palbo and the endocrine therapy. So assuming all of the options were approved and available to you via clinical trials, which next treatment would you recommend for this patient? Capecitabine, abemaciclib fulvestrant, exemestane everolimus, capivasertib fulvestrant, an oral SERD plus a CDK4/6 inhibitor, or I'm not sure. Okay, so let's go ahead and look at the second line setting, which is everybody's well aware we really have a plethora of options, and they're actually growing. We'll look at the post-Monarch data presented yesterday here in a moment here. This is a very nice table summarizing what we have seen over on the right in median PFS in a long list here of trials looking at second-line options in metastatic breast cancer. You can see down the center of the slide the percentage of patients in each of these trials that had received a prior CDK4/6 inhibitor. So in most of the trials, most of the patients had CDK4/6, but it wasn't 100%. And you can see, up at the top, we have the oral SERDs. We have 4 oral SERDs. We have the SERM, lasofoxifene. We have the PROTAC, what's called Vepdeg, vepdegestrant, a PROTAC. We got venetoclax, which is a BCL2 inhibitor, fulvestrant, and then we have the CDK4/6 inhibitors that have been looked at after progression on first-line CDK4/6. We have capivasertib, of course, the AKT inhibitor, and we have alpelisib. And you can see that the numbers are kind of mainly in the 5 to 6 month range, although, we can see 8.6 months for the elacestrant and the ESR1 mutant who had at least 12 months on prior therapy. Camizestrant in the ESR1 mutant patients, not all of whom had a prior CDK4/6. We have 9 months. So we do have some in the 7 to 9 months. We see down the bottom capivasertib, and we see alpelisib down the bottom. So inhibition of that PI3 kinase pathway is a little bit higher. At the 7 months, we know that this is an important mechanism of resistance to CDK4/6 inhibitors. The one thing we can now add to this list is the post-Monarch data with the abemaciclib. We don't have that on the list here, but that's another one. We'll see those data here. We'll look at that median PFS in the post-Monarch trial together. Before post-Monarch, which is our first phase 3, we had these 3 randomized phase 2 trials where patients basically all got first-line palbociclib with an aromatase inhibitor, and essentially upon progression, were randomized to basically fulvestrant plus minus with maintain ribociclib, and with PACE and Palmyra, it was change the endocrine therapy but keep the palbociclib going. So palbo after palbo, and maintain is ribo after palbo. And you see the only one that was positive was the maintain. It went from 2.8 months median PFS, which is really low, and we see really kind of low median PFS with fulvestrant in patients progressing on AI plus CDK, but it went up to 5.3 months with the ribociclib. The other 2, there was no significance at all. That was actually a statistically significant finding on PFS with the ribociclib. So we have the post-Monarch that we'll go over, and then later this year, we'll see the EMBER-3 results. And so this is a group of patients who will have largely had a prior CDK4/6 inhibitor first line, but it's not absolutely required. And then patients will have measurable disease, and they're randomized to the oral SERD imlunestrant, and that is versus basically what will likely be fulvestrant. Exemestane is an option, but it's likely going to be a fulvestrant imlunestrant direct comparison. And then if that's positive, then it will be imlunestrant plus minus abemaciclib that will be looked at statistically. So this may, I hope, give us a new combination of an oral SERD and abemaciclib, because that would be a very nice thing to have in clinic right now. These are the primary analysis results of progression-free survival in the post-Monarch trial, where patients had all had prior, mainly palbociclib, but there was some ribociclib in there too. Few patients had abemaciclib, so they're progressing on their first-line CDK4/6, and they're randomized to fulvestrant placebo versus fulvestrant plus abemaciclib, and we can see the median PFS with fulvestrant. So this was a more favorable patient population, because the median PFS with fulvestrant was higher than we've generally seen, 5.3 months versus 6.8 months with, that's an 8, the 6.0 months with the addition of the abemaciclib. The hazard ratio is 0.73, and you see it's statistically significant. So, we can see that if we look at the curves, they fall initially. And so there's about 25% of patients whose first scans, they're progressing. So they're resistant, and then the curves split, and they basically stay apart. So at the 6-month mark, for example, the PFS rates, your chance of staying progression-free. The patients were 37% with fulvestrant, 50% with the addition of the abemaciclib. So this is a finding, I think, that's in keeping with the MAINTAIN trial. It basically corroborates the MAINTAIN trial, and it's in keeping with several of the other studies we have seen in this post-CDK4/6 inhibitor. Again, these confidence intervals are basically overlapping. The only one I do want to point out is down the bottom there, which prior CDK4/6 inhibitor they had had. So you see with palbociclib, the point estimate's far to the left of 1 in favor of the abemaciclib. However, with the ribociclib, it's right on 1. It looks like after ribo, giving abema doesn't work. But first of all, those confidence intervals are wide. But number 2, there was a blinded independent central review. I'll show you the PFS here in a second. But if you look at the forest plot in the blinded independent central review, it changes. It doesn't hold up. It's actually to the left of 1. So this is not a robust finding, and the confidence intervals overlap. And that's a good example of why we don't make too much of these things, because the confidence overlap, and if you just look at a slightly different population, it changes. So I think that giving abema after ribo or after palbo, if you chose to do it, would be perfectly fine. Blinded independent central review was a secondary endpoint, and you see it's really, very positive, more positive than we saw with the investigator assessed. The median PFS went from about 5.6 months to more than 12 months. But the reason this probably is that there was a difference in interpretation about when patients progressed between the investigator and the radiologist. And this was a bit more than is usually seen in trials. And what they do is what they call informative censoring, where when the patients get to their point of progression, where the investigator called progression and the radiologist didn't agree, the patient stopped contributing data to the analysis at that time. And that was 51% in the abema arm and 30-something%. And so basically what the statisticians say is this can falsely elevate the median PFS from the abemaciclib. So this likely is not 100%. This is not probably fully correct. If they had agreed with each other, this would be a different result. This would be closer to the primary analysis. Nothing new on toxicity. We're all very familiar with the fulvestrant abemaciclib. Here we see the grade 3 diarrhea here of 4%, so that's good, and the grade 3/4 neutropenia about 29% or so. So no new signals here. So this patient, has had a reasonable response to the palbociclib and endocrine therapy. After 18 months, she's progressing, but she's asymptomatic in her bone and her liver. So she's progressing, but it's not bothering her. She has no targetable, no target to go after. So 2 questions. Cynthia and then Javi, what would you treat her with? I know there's a bunch of options. And secondly, what do you think the post-MONARCH data are going to bring to our practice? Assuming FDA approval and NCCN endorsement, et cetera.
Sure. I think first of all, I would make sure that this patient still have ER-positive breast cancer, because she had a new liver lesion. Would you want to biopsy that? And also, would you also send that for genomic testing, just to make sure that we're not missing any, like, for example, PIK3CA mutations or PTEN alteration. Sometimes, tissue testing may also have some discordant compared to the blood testing. But I agree with you. If this is still ER positive, I think the post-MONARCH brings us another option with getting abemaciclib and fulvestrant as an option because this patient has no genomic alterations. Our other option would be everolimus plus exemestane. I think we don't really have prospective studies of exemestane plus everolimus post CDK4/6 inhibitor. Our data mostly are retrospective, and we know that the PFS is usually around like 4 or 5 months ish. So I think abemaciclib plus fulvestrant after the post-MONARCH data release, I think I would use that, assuming that it's going to be approved.
Mm-hmm. How about you, Javi?
No, I think you did a terrific summarize. So, in the clinical practice, we have many times patients with a very long period of time with ribo, abema, or palbo that experience some degree of progressive disease, but this tiny progressive disease is just bone only, or maybe a small liver mets, but all the other is under control. So usually what I have been done in this patient is to change from palbo to ribo, or if I am on ribo, what I do is just go for surgery or radiation therapy, and I continue with endocrine therapy plus palbociclib or ribociclib, whatever the CDK is. So I think that today, with this data, it encouraged me to use abemaciclib and to continue with CDK4/6 inhibitor. So if the question is, would you change from palbo or ribo to abemaciclib as a new standard of care in the second-line setting? My answer is no. But if you're asking me, are there patients in the clinical practice where you think that this strategy is going to be good enough? The answer is certainly, and not a few. Many patients with a small progression of the disease, that instead of just going for surgery or something and continue with the same CDK, now I would change into abemaciclib. So this trial, in my opinion, helps me for the clinical practice, and afterwards I will delay maybe the start of using Capiva or inavolisib or alpelisib or whatever.
Right. And I might even do that even if I had a target. You know, if somebody was doing very well on CDK, even if I had an AKT or a PIK3CA, I still might do that. And then, of course, go to inhibition of that pathway. You know, I might do that. So I agree. This gives us another option for these patients that we don't have a particular target for. So if you wouldn't mind going ahead and using the QR code again, there'll be the options that come up for how would you treat this patient 18 months on Palbo AI, now progressing asymptomatic small volume disease. How would you treat this patient? Now we have a different scenario. Now she's got, yes, yeah, go ahead.
So, so we learned today about Destiny Breast 06. So I have started to hear that, wow, now maybe with the 13 months, 14 months, 12 months, whatever the PFS is, let's go to antibody-drug conjugates now. So I think that we have to be very cautious. I think that we have to, this is a patient that I think that the benefit of endocrine treatment is very clear. So I think that we have to continue with endocrine-based therapy. And once we say, listen, it's time to move into the chemotherapeutic field, then is what we can discuss about the role of ADCs. But certainly, this is not a patient for ADC.
Yeah, yeah. Thank you for that, because that's something. The data are very strong for DB06 with the TDXD. But I totally agree. This is a patient whose quality of life is going to be better continuing on endocrine therapy.
Yes.
Just gives her more options too, to utilize. But now she's been progressing after just 10 months on her CDK4/6 palbociclib and endocrine therapy. And she's still got asymptomatic disease, but now she's got an ESR1 mutation. And she's got a PIK3CA mutation, but she's only on for 10 months. So, assuming all the options are available to you, what would you recommend to this patient? So she's got ESR1, she's got PIK3CA, she only had 10 months on palbociclib, but she's asymptomatic small volume disease. 1, exemestane everolimus. 2, endocrine therapy alpelisib. 3, fulvestrant capivasertib. 4, oral SERD monotherapy. 5, oral SERD plus CDK4/6 inhibitor, or I'm not sure.
That's the music.
All right. So let's go ahead and take a look at some of the data here. So most ESR1, which is estrogen receptor mutations, are acquired. If we go looking for ESR1 mutations in the primary breast cancer, we'll find them 1% or less. They're really acquired, particularly under the selective pressure of metastatic aromatase inhibitor therapy. I think we have still some to learn for patients who are on adjuvant aromatase inhibitor therapy. There's the incidence of having an ESR1 mutation in first-line metastatic ranges from about 5% maybe up to 15%. So you can pick up an ESR1 mutation after recurrence on an adjuvant AI or after an adjuvant AI, but you really pick up ESR1 mutations, the cancer does, after progressing, for example, on first-line AI plus CDK4/6 inhibitor, up to 50%, as you see there, as was illustrated in the EMERALD trial. And if you just look, we're looking here at on the left on the bar graphs, AKT, HER2 mutations, ESR1, PIK3CA. The pink and the red are basically discordance, where the tissue and the blood, the ctDNA, they don't agree with each other. And so if you do both, you'll pick up more. There's a recent paper published in JAMA Network Oncology by the Tempest group, thousands and thousands of samples looking at matched blood and tissue on patients, multiple malignancies. And their bottom line was that if you look at both tissue, metastatic tissue, if you have it, if not the primary, and blood, you'll pick up something like 22% more mutations, targets to go after for therapeutic choices. Of course, we like the blood because it integrates all the sites of metastasis, not just the one that you biopsy with the needle biopsy. As you know, there are multiple ways to target that estrogen receptor. That mutant estrogen receptor is constitutively active. It still homodimerizes. It needs no ligand, and it basically drives ER transcription without any ligand whatsoever. Highly active. And there are multiple classes now of drugs to go after the ER, and they're looking very promising. There's lots of trials going on. I'll illustrate some of them. But the one that led us to a new agent, of course, is the EMERALD trial. 100% of patients had progressed on a CDK4/6 inhibitor, generally with an AI, and they were randomized to mostly fulvestrant versus elacestrant. And there were co-primary endpoints, the intent to treat, as well as the ESR1 mutant population, and that was 50% of patients had an ESR1 mutation. And basically, what was seen, the FDA approved on the right those patients with an ESR1 mutation. We see a nice improvement, particularly the tail of the curve. There's just a greater percentage of patients. The hazard ratio is 0.55, a much greater percentage of patients getting out, 20-25% of patients getting out more than a year. So, and that was more impressive than in the intent to treat, as you see on the right. It was the ESR1 mutant population, particularly in the middle and on the right, patients who had at least 12 months of benefit from their prior CDK4/6 inhibitor. Their median progression-free survival was 8.6 months. So this really tells us it's more the endocrine therapy sensitive population we want to be aiming the elacestrant. So the sooner we give it in the natural history, the better, because the cancer becomes more endocrine therapy resistant as we go on with various treatments. So this just tells us, get it in early, look for that ESR1, but just really confine it to those who have had a year or more of the CDK4/6 inhibitor. Now, what about the double mutants? So this is the ESR1 mutant population. We're looking at patients who got at least a year on their CDK4/6, so the favorable population. And on the left, there's a PIK3CA mutation, and on the right, PIK3CA is wild type. You can see patients do better with the elacestrant. This is single agent elacestrant. On the right, they do better with the wild type. There's still a benefit. However, on the left, these patients still benefit. The median PFS about 5.5 months. Of course, we're really looking forward to the day we can put elacestrant together with PI3 kinase and AKT inhibitors. That's what we really want to do for those patients. We don't have those data at this time. And basically, they looked at liver or lung mets, visceral, bone mets, PIK3CA, HER2 low, P53 mutation. They really couldn't find a subset where you wouldn't consider giving the patient elacestrant, including in the PIK3CA mutant. If somebody's got the natural history, the natural history speaks to endocrine therapy sensitivity. I think that's still a reasonable option for these patients. So we have multiple trials that are going to be reading out here. We have in the first line setting, head-to-head against AI, CDK4/6 inhibitor. We have camizestrant, which is one of the oral SERDs with a CDK4/6 inhibitor. We have vepdeg, which is head-to-head against, again, AI plus CDK4/6. So and giredestrant has already completed the lidERA trial. No, sorry, that's persevERA trial. First line, again, that's been completed. So that's probably going to be the first one to read out, which is first-line giredestrant with CDK versus AI plus CDK. With this very interesting, there's the Serena trial, the Serena 4, I mentioned that, that's the camizestrant. The Serena 6 trial, very, very interesting. That's when patients are on their AI plus CDK4/6. You're monitoring every 3 months their ctDNA, looking for the emergence of that ESR1 mutation, and then they're randomized to continue their same therapy, provided they haven't recurred, versus switch over to get camizestrant plus their CDK. So we have a whole bunch of trials coming out over the next couple of years. This just shows us camizestrant head-to-head against fulvestrant. And we can see a significant improvement in median PFS there with the camizestrant compared to the fulvestrant, two doses there. So we can see the median PFS there in the 7-month range versus about the 3-month range with the fulvestrant. So imlunestrant as well, another of the oral SERDs. You can see this heavily pretreated population, and it's all comers, both ESR1 and wild type. You can see on the left the waterfall plot with imlunestrant, but then on the right, when you add abemaciclib to imlunestrant, you get a very nice looking waterfall plot. Likewise, imlunestrant with everolimus, imlunestrant with alpelisib. So we're really looking forward to having some doublets, particularly for these patients with ESR1 mutations. So we look forward to the EMBER-3 trial in the top left, the imlunestrant with the abemaciclib, the PERSEVERE study, that is first line with letrozole, palbociclib, and giredestrant with the placebo giredestrant or the giredestrant real drug and palbociclib, letrozole, placebo. The Serena 6 is the camizestrant first line versus AI with palbociclib, and the Serena 6 I just described. So lots of data. And then in the adjuvant setting as well, we have giredestrant, which was head-to-head up front versus a standard endocrine therapy that has completed enrollment. Imlunestrant is being evaluated as a switch after patients have been on endocrine therapy 2 to 5 years. They're randomized to more of the same or switch over to imlunestrant. Camizestrant in the Cambria-1 trial is also a switch trial. There's a second camizestrant trial head-to-head up front. And then Vepdeg is also, elacestrant is going to be going into the adjuvant setting soon. So we have a lot of adjuvant studies also ongoing. So with that, I'm going to turn us over to the very important PI3 kinase pathway, which causes so much resistance in our patients. Thank you, Cynthia. Thank you. Thank you.
Okay, it's such a pleasure to be here today, and thanks, Joyce. It's so nice to be on the panel. So I'm going to talk to you about the PI3K AKT pathway, and the reason is this is such an important pathway that mediate endocrine resistance and also resistance to CDK4/6 inhibitors. You know, Joyce just talked to you about ESR1 mutation because those mutations kind of causes this ER being active without having to bind to estrogen, but this pathway similarly can activate estrogen receptor. So so this is a really kind of a brief schema of this pathway. You know, it's really intracellular. It's a major survival pathway. It mediates the growth factor signaling pathways from extracellular signals as well as intracellular. So for example, signals from EGFR or HER2, FGFR can all go through this PI3K, AKT, mTOR signaling, and also inside the cell, like RAS signaling can do that as well. So importantly, in ER-positive breast cancer, there can be multiple mechanisms to activate it. For example, PIK3CA, which is the gene that's encoding the alpha catalytic subunit of PI3K, which is here is called P110 alpha. So that's the gene that can be mutated in 40% of the ER-positive breast cancer. And these mutations tend to be like really activating mutation, leading to like phosphorylations of downstream signaling pathways and making cells grow. And then also the negative regulator, for example, the P10 usually is dephosphorylate, you know, PIP3 to PIP2, really counteract this pathway activity. It can be deleted or mutated, so you have a loss of function, and that can happen in a small percentage of ER-positive breast cancer. In addition, there are mechanisms that can epigenetically silence that gene. Also, you've heard AKT mutation, especially AKT1. It can happen in about 4 to 5% of the ER-positive breast cancer as well. So when this pathway is active, it can phosphorylate estrogen receptor. So now it doesn't need the ligand as well. So, and in preclinical studies, like if you deprive estrogen from ER-positive breast cancer cell line, they would activate this pathway as a mechanism to try to survive. In addition, even with CDK4/6 inhibitors now, because that's targeting the cell cycle, and the PI3K pathway actually can activate the CDK4 pathway as well. So there's crosstalk between ER, CDK4/6, and PI3 kinase. So really, this pathway has become a major mechanism for us to overcome resistance to these. So, what are the drugs that are available now that we can target these pathways so that we can still treat patients who progress on CDK4/6 inhibitor? So the first drug is alpelisib. This is the alpha selective PI3 kinase inhibitor. So we talked about P110 alpha. That's the gene most commonly mutated. So this alpelisib would target that P110 alpha. So this was approved initially based on SOLAR-1. That's when CDK4/6 inhibitors was not widely used. In that trial, there was very few patients had, CDK4/6 inhibitor previously. So in the BYLieve trial, specifically, they were looking at what's the activity of alpelisib if you already had CDK4/6 inhibitor. So here we're just highlighting the progression-free survival in the cohort A. So these are the patients who progress on aromatase inhibitor plus CDK4/6 inhibitor, and when they progress, and if they had a PIK3CA mutation, then they put on, alpelisib plus fulvestrant. And here you can see the progression-free survival is 7.3 months, so it's really robust. And also the clinical benefit rate was over 50%. So really, this indicates that this is an effective agent. Then we have capivasertib. So this is more recently approved and based on the CAPItello-291. So this is a pan-AKT inhibitor. So there are 3 AKTs, AKT1, 2, and 3. And so in this study, they selected patients who progress on prior endocrine therapy or also endocrine therapy plus CDK4/6 inhibitor. So compared to the prior SOLAR-1 trial, now we have CDK4/6 inhibitor already. So this trial required that you have to have at least 50% of the patients have had prior CDK4/6 inhibitors, and these has to be endocrine resistance, but you cannot have more than 2 lines of endocrine therapy, So, and they also have a requirement of hemoglobin A1C because, targeting this pathway can cause hyperglycemia. So hemoglobin A1C has to be less than 8%. And then they randomize patients to fulvestrant plus placebo versus capivasertib plus fulvestrant. As you can see here, so capivasertib is given 4 days on, 3 days off each week. It's oral medication. It's just given differently than what we normally do. So this is in the overall patient population, so the intent to treat. As you can see, the curve separates very well. So with fulvestrant placebo, the PFS is 3.6 months, and then now with capivasertib, you have 7.2 months. So the adjusted hazard ratio is 0.6, and this is statistically significant. Importantly, in the PI3K or AKT pathway altered population, so this is referring to if patient had PIK3CA mutation or PTEN mutation or AKT1 mutation. And here you can see, the PFS improvement from 3.1 months to 7.3 months, and the hazard ratio is really 0.5, which is better. And when you look at the non-altered, I think if you only limit to the non-altered population, the significance was not there. So FDA approved it based on that. And then, however, when you look at the population who had prior CDK4/6 inhibitors versus no prior CDK4/6 inhibitors, you can see that even if you have capivasertib, the PFS is, less, is 5.8 months, yes. 5.5 months compared to without prior CDK4/6 inhibitor, the PFS was much longer. And then, at last San Antonio, there was some subset analysis based on, what particular PI3K pathway alteration, this matters. As you can see that regardless whether you had PIK3CA mutation or AKT1 or PTEN alteration, adding capivasertib is better than without. So that's, and then, FDA has approved this drug in patients with metastatic hormone receptor positive to negative breast cancer who had PI1 or more of the PIK3CA, AKT1, or PTEN alterations progress on at least one endocrine-based regimens, or if they recurred on or within 12 months of completing adjuvant therapy. They do have a companion diagnostic like Foundation-1 CDX, but I think in reality, no matter which one, next-gen sequencing that you use, I think that's all fine. And then I think most exciting is the INNOVA120, really trying to bring these PI3K PI3K inhibitors in the first-line setting for those that with with PIK3CA mutation, but are, very endocrine-resistant population. So this is not yet approved yet, but we hope that it will be available to our patient soon. So this is the first-line study in patients, however, high risk. So these are the patients who recurred on adjuvant endocrine therapy or recurred within 12 months of completing their adjuvant endocrine therapy. And there is a very strict blood glucose requirement. It has to be less than 120, and hemoglobin A1C less than 6%, which is fairly strict. So patients were randomized to, standard of care is fulvestrant plus palbo plus placebo, and then the experimental arm is triplets, now adding inavolisib. So inavolisib here is a little different than alpelisib. It is alpha selective PI3K inhibitor, but also has ability to degrade the mutated PIK3CA. So they're potentially a better therapeutic window with this drug. So here you see the dramatic improvement from 7.3 months in PFS to 15 months with the addition of inavolisib. As you see, this is a fairly resistant population. Even with CDK4/6 inhibitor, PFS is only 7.3 months if you didn't do the triplets therapy. So I think this is very exciting. In the overall survival, although this is immature, I think there's a trend that the triplets might be better. And then it does have some side effects. However, they seem to be manageable. You can see that some of the side effects are related to palbociclib with myelosuppression. So, for example, you can see the neutropenia. The grade 3 and 4s are, as you anticipate with palbociclib. And there's some patients with thrombocytopenia, anemia, but also there's some side effects related to inavolisib, for example, stomatitis, and diarrhea, hyperglycemia, nausea, and rash. But grade 3 events were very low. So I think, and this seems to be more manageable than other other PI3K inhibitors. So in addition, in the second-line setting, so this is a trial in progress. So INNOVA121, so looking at inavolisib plus fulvestrant versus, now comparing to our established alpelisib plus fulvestrant in the hormone receptor positive to negative PIK3CA mutated metastatic breast cancer, after progression prior CDK4/6 inhibitor and endocrine therapy. So this is, still pending. So we, the INNOVA120 hopefully can bring this drug early in the first line to the high-risk patients, but then for the lower-risk patient, potentially there will be safer PI3K inhibitors. And then we talk about everolimus, Bolero-2 actually was, done years back. That's when we have the mTOR inhibitor in combination with exemestane. As you can see on the left side, the PFS significant improvement in the endocrine-resistant metastatic ER-positive breast cancer, although the overall survival did not reach statistical significance. So in retrospective analysis, so here is listed a few trials. The EverMet is a retrospective analysis of patients who had prior CDK4/6 inhibitors, looking at their, the PFS is about 4.9 months. And then there are other trials, for example, the Trinity one. So in this trial, they, patient all progressed for CDK4/6 inhibitor, but also everolimus was combined to ribociclib, so kind of triplets with exemestane ribociclib is 5.7 months, and then the other retrospective study showed also 3.6 months. So, it is definitely an active regimen based on the retrospective analysis. We don't have a prospective trial, however.
Thank you, Cynthia. Excellent. I love the science that you brought in there for us. Really, really cool how the PI3 kinase phosphorylates ER and renders it ligand estrogen independent. So very, very important. So let's have a little a discussion here. And this patient has ESR1. She has PIK3CA. She only got 10 months on the CDK4/6 inhibitor. She is asymptomatic with small volume disease. And one of the questions, and we got some really good questions that have come in here, and one of them is, well, like, how do we decide between alpelisib, if you want to consider going after the PIK3CA? How do you decide? So what would you do, Javi, and then how do you decide between the agents available for the PI3 kinase pathway?
So first of all, for me, it's important the time the patient was on treatment with CDK4/6 inhibitor to decide if I go for a new cert, elacestrant in this case or not. So if the median PFS is short, I would consider not going to elacestrant. Okay. So for me, this is a patient for a PIK3CA inhibition, and we do not have data for inavolisib in this patient population because it's a patient resistant to CDK. So I'm sure I would go for Capiva in case I could. Why? Because two reasons. The first one is the toxicity profile seems to be much better compared with alpelisib, and second, because the phase 3 is a prospective clinical trial in patients whose the great majority received CDK4/6 inhibitors. So I would go for Capiva plus fulvestrant here.
Thank you. How about you, Cynthia? How do you think about this patient?
Yes, I agree with Javi, definitely. I think, if this patient have had longer PFS on the prior CDK4/6 inhibitors, so for example, more than 12 months, I may be thinking about either elacestrant or even the abema plus fulvestrant. Ideally, we would like to have both targeted, but yeah.
And how do you decide? We got, let's assume we got even inavolisib, we got capivasertib, we got alpelisib, we have everolimus. How do you think about what to do for this patient?
Okay, want me to
Yeah,
answer?
yeah.
Okay, so this patient has ESR1 mutation, also have a PIK3CA mutation. So you mean inavolisib also has shown activities in the, I guess we don't have that Innova 121 yet.
Right, and
Yes.
she's probably not the
Yes.
candidate for that.
Right, she's not a candidate for that. So if she has, long PFS on prior CDK4/6 inhibitor, like for example, 18 months, and she has limited disease visually, like for example, bone disease, and although she had the PIK3CA mutation, I still might consider elacestrant as a monotherapy because of better tolerability. And in their analysis, looking at subset of PIK3CA mutated, the double mutated population, there's significant improvement. I think PFS was 9 months even with elacestrant in those, prior. So with a longer PFS on the prior CDK4/6 inhibitor. However, if the patient, had more, more visceral mets and, you wanted combination therapy, I think I would favor capivasertib. Ideally, you want combination with elacestrant.
Yeah, ideally we do,
Yeah.
right. For the same reason, just tolerability
Yes.
ability to get the capivasertib in easier for her than the alpelisib. Yeah,
Yes.
yeah. I agree. One other question that came in here was just about adjuvant abemaciclib in germline BRCA mutated patients. We did see some data just recently from ESMO Breast. That's up to small numbers of patients with known germline BRCA mutations in monarchy, but it was the same benefit that you saw with the same hazard ratio, about 0.65, that you see with the abemaciclib. So abemaciclib works fine in the wild type, works fine in the germline. That was very reassuring data to C. And what that means, I think, is that if you got a very, very high-risk patient, you could start with olaparib and consider, now I know this is not obviously available all over the world, but hypothetically, if somebody's really high risk for more nodes, you might like to consider the abemaciclib, you know, if it's available to us, you know. So that's what at least it says to me. So yeah, just take a moment, if you would please, and answer that question that we just asked about. What are you going to do with this patient with the double mutation? If you would do that, that'd be great. We have a couple more questions we'll do here. Great, let's see here. Go ahead. Okay, so our Q&A, we're going to come back. I just want to make sure that I show you here on the next slide. If you could go forward, we'll just want to make sure I show you the at the end there, just how to just to go ahead and get your post-test at this site here, the peer review, and evaluate for get your CME credit. Download the slides, the practice age, watch a replay of this event. You just want to see it again. That's how you can do it, right there. So I just wanted to show you that. But you know, basically what they're saying here is like, you know, how are we going to sequence all these agents? I think we've kind of talked about that somewhat. You know, every patient's individual. You know, really, it's there's a lot of variables that go into it. I think by and large, it's probably fair to say that we're going to stick with the patient populations that were studied in the trials. You know, inavolisib, you know, post-monarch, et cetera. But we do have choices. We have post-monarch versus going after the PI3 kinase pathway. But we, you know, and there's not a right or a wrong answer, you know, on that. So any other comments you want to make about, we've got elacestrant, you know, so we've talked about a lot of these issues, but anything else you'd like to add about sequencing?
No, I think that you made a very good point. So I think everolimus continues to be a good drug, but we have limited data only coming from real-world evidence, as you showed, with a 4.5 median PFS after CDK, which seems to be shorter compared with the new pathway inhibition. We have with Capiva something much better than that. We will have with Inavo in the future, I hope so, much better data. So I think that everolimus after CDK is, in my opinion, my last option. It's not bad, but is the last option here. So I think that the more data we have in a patient like this, I would agree with Cynthia, is with Capiva. So I think this is the most reasonable approach. I think that inavolisib in the high-risk patient population in the, let's say, first-line setting, maybe would be my preferred option. And let's see what happens with the Inavo 121. And we should not forget that in the future, maybe we will be able to combine all these agents with a new oral SERDs. We are going to run a study tomorrow. We will start tomorrow, but in 2 months or so, which is elacestrant with or without everolimus in the estrogen receptor gene 1 mutation. So I think that in the future we'll see more combinations that might help us to decide which are the best options to treat our patients.
Yeah. So cool. Excellent.
Yes.
Well, thank you very, very much for coming, everyone. I hope this has been useful to you, and you can download some good resources there. And thank you guys so much for coming out tonight. It was a great pleasure. Good evening, everyone. Thank you.